I'm Dr. Anthony Kaveh, a Stanford and Harvard-trained anesthesiologist and integrative medicine specialist. And today we're going to talk about Kenneth Smith's tragic story of a botched lethal injection. 8% of all lethal injections in the United States are botched. Actually closer to 7%, an outrageous number. I'm not here to talk about the ethics of capital punishment, but I am here to talk about the unknown medical side that doctors have deep controversy in, but the layperson and voters have no idea about. And you need to know why there are so many failed attempts at lethal injection and what these new nitrogen asphyxia or nitrogen hypoxia techniques are, and what was used specifically in Kenneth Smith after the lethal injection was completely botched and failed. In fact, it was canceled because it failed so miserably. So this 7% lethal injection question is huge to understand why it happens. And we're going to talk about what went wrong specifically in Kenneth's case, why. We're going to talk about the Eighth Amendment rights that have been violated, the cruel and unusual punishment, the big pharma opposition, the doctor opposition, what that whole nitrogen hypoxia technique is. And I'm even going to do a demo on myself, not with nitrogen hypoxia, but with something kind of similar so you can understand and make an opinion on whether you think this is an appropriate alternative to lethal injection. So as we get started here, I want to remind you that in the comments, please keep them respectful. This is clearly a charged topic. So first off, you need to know that doctors' organizations completely oppose MD or physician involvement with any forms of capital punishment because we are healers, not executioners. The American Medical Association, the American Board of Anesthesiologists, and American Society of Anesthesiologists are clear on this message. Anesthesiologists are often targeted as being executioners because we use the drugs that are similar to lethal injection every day in the operating room, in rooms like you see here, on operating room tables like you see here, with gases that we sometimes use that are similar to those used in patients. The number one cause of these botched injections is because doctors are not involved, specifically because the IVs don't go in the right places. Sometimes there are emergency personnel like EMTs or non-medical personnel sometimes with maybe enough training to try to jab an IV in someone. In Kenneth's case, it sounds like they missed a peripheral IV, meaning an IV placed somewhere in the arms. Then they tried to place central access. And judging by the attempts at him being stabbed in the chest, it sounds like they tried to do first an internal jugular vein, central venous catheter in the internal jugular. And then after that failed, they tried to go into the subclavian, which is just under your clavicle bone. It's actually a pretty risky technique if you don't know what you're doing. It was so many failed attempts at trying to get IV access that they actually ran out of time and they had to cancel his execution. So why are doctors not doing this? Because they do not want to be involved. In fact, anesthesiologists risk losing their board certification if they are involved in any form of lethal injection or capital punishment. And the reason why this is such a big problem is because if non-trained personnel are trying to use injectable medications like anesthetics, we'll talk about those medications in a minute, how do you ensure unconsciousness before the lights go out? Because if someone is in agony as they are dying, that in court cases has raised concern for violating that Eighth Amendment right, the right against. So if we can't ensure that the patient is unconscious, because we can't have anesthesiologists who are the doctors best trained to assess consciousness, because it's what we do in operating rooms like this all the time, whether it's from gases or from medications like the propofol I'm holding here, how do we know that the patient is unconscious, or that not the patient, but the inmate is unconscious before they die? Well, there's a 3-step protocol that was developed to help minimize the risk so that untrained or non-medical, non-professional medical personnel can administer this cocktail, if you will. It's kind of a disgusting way of talking about it. It involves 3 medications. A hypnotic, sodium thiopental was the original. I'll tell you why it's not used anymore. A paralyzing agent, usually a derivative of the substance obtained from the poison Aerodart, a curare type drug. And then high doses of potassium, which stop the heart. Interestingly, we use potassium in the operating room to actually stop the heart in open heart surgery. But in those cases, the patient is connected to a cardiopulmonary bypass machine or a heart-lung machine. So that keeps them alive as the heart is paralyzed so it can be operated on. Not so in this case, obviously. The problem here is that it's not just doctors that don't want to be involved with capital punishment, neither does big pharma. In fact, sodium thiopental was produced by a manufacturer that actually wanted its medication to not be used in any way, shape, or form with lethal injection. That sodium thiopental was the OG truth serum, if you will. It does render unconsciousness. It's from a class of medications called barbiturates. Different than the white stuff, but still effective for rendering a patient unconscious for anesthesia. But after sodium thiopental was banned from use for lethal injection, Hospira actually took it off the market altogether. That's the manufacturer. And we don't even have access to sodium thiopental in the United States for anesthesia in the operating room either today. So it's completely not available. Many have tried to come up with alternatives like midazolam, which is the amnestic medication we use in surgery, or hydromorphone, also known as Dilaudid, a potent opioid, or even other barbiturates like methotrexate. But there is no gold standard, once again, because doctors aren't involved and drug companies certainly do not want to be involved with this process either, especially when non-trained personnel are on the execution team. So the question that you all need to ask yourselves, no matter where you land on the ethics of capital punishment, is do you have physicians involved in this? Or you risk having this absurd number of botched lethal injections by having incompetent execution teams. Once again, not about the ethics of capital punishment, very charged topic, but how it's played out is a tangible, pragmatic question that if you're voting on this in your state, you need to know about. Not just yes or no for capital punishment, but how is it happening and who is doing it? Because the current state of affairs really is not optimal, at least for most individuals. Now, I want you to share your thoughts below. Please keep it respectful, appreciating the sensitivity of this topic. And in that vein, if you appreciate me broaching these controversial topics, these important ethical questions, but ones that you probably don't hear about in the news, hit that like button and subscribe. Keep up with my live streams. I want to hear from you so you can empower yourself with knowledge to advocate for yourself and to better ultimately advocate for your health, not in cases of capital punishment, obviously, but to address the mental health that comes before someone falls into this deep downward spiral where they do end up on the books for something horrible like Kenneth Smith. That was my light that fell over here, by the way. So when you see a live stream of me, you know that it's live when things are happening like that. But anyways, if you also want to get more in-depth information from me, you can join the Medical Secrets Exclusive Access. The link is below where we have our private Zoom streams. The next one is coming up this weekend, so I hope to see some of you on there. But let's talk about nitrogen hypoxia. And this is where the demo of me is going to come in, because I want you to understand a little bit about what hypoxia is and what the nitrogen has to do with it and how it's actually a really big deal in the operating room here for all patients having anesthesia. So first off, you got to recognize that nitrogen appeals to execution teams because it's used in so many industrial settings that there's no concern for banning it for medical use because you can get it from so many other sources, unlike sodium thiopental back in the 90s. So most of the studies around nitrogen have actually been in industrial accidents where unfortunate individuals have asphyxiated or have gone hypoxic and died from nitrogen leaks. But in 1963, a study was actually done on 3 individuals, 3 volunteers, who were given high concentrations of nitrogen and asked to breathe in and out very deeply. And they monitored how long it took for them to lose consciousness. So why do you lose consciousness is the first question. Well, anytime you are inhaling air, it's 20% oxygen and about 80% nitrogen. There's a little bit of other gases. If you want proof of that, this is an oxygen mask here. You can actually see what I'm going to breathe out here in a second. So as I'm talking to you, I'm going to exhale and look at what my expired oxygen is. Already you can see that it's 21% right now without me talking into it. If I exhale, watch what happens. You're going to see my CO2 rise up here. And if you look in the corner, you'll see that this number for oxygen goes down to 18%. So I am inhaling that 21%, 21%, and exhaling 18%, because a couple percent is being uptaken by my body as it's being consumed by the cells everywhere in my brain, kidneys, heart, etc. Now, if you breathe in just nitrogen, you will quickly consume all of the inhaled and exhaled nitrogen very, very fast. It displaces oxygen. And if you don't have oxygen in your bloodstream, you develop what's called hypoxemia. Emia refers to anything in the blood, like leukemia. Leuc is white, referring to the white blood cells. Emia, the blood. Leukemia, lots of white blood cells in the blood. Or anemia. You've heard of people who are anemic. A refers to lack of. Emia, the blood. Anemia, lack of blood. Well, hypoxemia refers to hypoxia or hypoxic, low oxygen, hypoxia. Emia, hypoxemia, less blood, less oxygen in the blood. Now, when you have less oxygen in the blood, less oxygen is going to reach all the organs that need that oxygen. Your heart, in particular, is the most metabolically active. So you'll see here that 8 to 10 seconds quickly depletes the oxygen supply that your brain needs. That's how long it takes your heart and brain to stop working. You begin to see dimness and might see blurry vision, can't think straight, and eventually will black out and lose consciousness in about 20 seconds. It's from this study that most of this 20-second rule has come up from, by the way, from a study nearly 50 plus years ago. Now, other individuals also are in hypoxic environments. Anesthesia is a big one. In fact, it's such a major concern that all these ventilators have a very special stopgap. As you turn the nitrous oxide knob that you see here in blue, you cannot raise it all the way to 100%. There's actually, if you look, as I turn the blue, the green moves with it. The green is oxygen. That's to prevent a hypoxic mixture. Because when we give nitrous oxide, which is laughing gas, not the same as nitrogen, like in the nitrogen hypoxia capital punishment, but when we give nitrous oxide at high concentrations, these ventilators have a breaking point where it will force the oxygen to also go up, so you don't accidentally give someone pure nitrous oxide, because they will die. They'll be in an altered state of consciousness while they die, but you need to have oxygen as well. So these ventilators, for human beings having surgery, have that stopgap. It's a mechanical coupling there where you can't increase the nitrous oxide too high. So pilots don't have nitrous oxide, but they do have low partial pressures of oxygen as they go up in altitude. Same with those going up to Mount Everest. Now, that's why they need to have supplemental oxygen. They had to pressurize the cabins to ensure that there's an adequate amount of oxygen to prevent that hypoxia. Different than inhaling pure nitrogen gas, that will immediately displace, and I'll show you on myself in a minute a little bit how that looks. But it's been cited in pilots that once you go into hypoxic environments, within seconds to minutes, your judgment is totally clouded, you're not seeing straight, and eventually, of course, you'll lose consciousness as well. Scuba divers are a different, very fascinating cohort, because as you descend, the partial pressures of the oxygen and nitrogen that you're inhaling in your tank actually increase. But the nitrogen increases so high that it can cause what's called a nitrogen narcosis. You can actually get drunk or inebriated when you're scuba diving, especially at deeper depths. So that's actually very different, because you still have oxygen that's being delivered to your vital organs. But the nitrogen partial pressure, the nitrogen has been pressurized so high that it can also interfere with oxygen uptake and has unusual characteristics in the brain, which is why you need to ascend. Not immediately, you'll get the beds, but you need to be very careful so you don't end up drunk. You don't want to be drunk when you're 50, 60 feet underwater for obvious reasons. Now, let's talk about this important point here, which is why everyone talks about putting lethal injection aside, because like we said, you don't have doctors doing the IVs, you're botching them. They're saying, well, nitrogen Hypoxia is a good alternative because you don't need an ND to place an IV. You just slap the gas on the inmate, slap the mask on the inmate, and they inhale the nitrogen, displaces the oxygen. Within seconds, as you can tell, you become unconscious. So it's, in a sick way, I guess, a good alternative, or it's a viable, looks like a good option. Kind of weird to say that, but you know what I mean. The problem is that losing consciousness quickly does not mean that it's painless. That's a flaw. For example, when you get propofol, you'll lose consciousness relatively quickly, but boy, does it burn as it's going in. Ask anyone who's had surgery, unless you're buffering with lidocaine or it's going into a big vein. Techniques that I've shared on my channel, what I do with my patients to minimize the pain as they're losing consciousness. But if you're going to say that no lethal injection, nitrogen, because it's painless, because it's fast, that doesn't quite add up. And Kenneth's case specifically shows the failure of that logic, because he held his breath as they were blasting nitrogen into his face. I'll show you myself what that looks like in a second. But the last thing I'm going to talk about here is the functional residual capacity. This is your tank of oxygen in your lungs. It's several hundred cc's, where it's the amount of volume that you have in your lungs at the end of a normal breath. So that's like your gas tank, the extra gas, usually that oxygen. In fact, before you fall asleep, we ask you to breathe 100% oxygen to fully maximize the oxygen in your functional residual capacity, so that as you stop breathing, as we place the breathing tube, you have that gas tank of extra oxygen to keep you going. Now, when you're inhaling pure nitrogen gas, your gas tank gets depleted within seconds. Very, very fast. Now, if you watch me exhale with room air, you saw I was around 18%. What happens if I hold my breath for 30 seconds? How much extra oxygen is in my gas tank? How low do you think my exhaled oxygen will go? Meaning, how much oxygen is taken up by my body and how much is extra in my lungs? I will give a shout out to whoever gets closest to it. So I'm going to look at I'm looking at your comments here. What percentage is my oxygen exhaled after I hold my breath for about 30 seconds? All right, Orbital says 18. Let's see what it is. All right, I'm going to hold my breath here, and you're going to know that I'm not cheating, because you're going to see the CO2 and the white here bump up when I exhale. So if I'm breathing in and out, you'll see that I'm cheating. All right, 1, 2, 3. All right, what's the number going to be? So my FI is the inspired, is 20. My exhaled is 13. So that means that I inhaled 21%, because I told you I was inhaling room air, no funny extra gas. I had enough FRC, functional residual capacity of oxygen, that I was still exhaling out at 13-ish%. So who was closest? Someone said 0. I'm not dead, so ha, ha, ha. Someone said 30. I can't exhale out more than 21%, because that's what I'm inhaling from room air. The closest was, the chairman said 11, so that's good. That's close. The show Life Young says 15. Oh, I think Arakel Toros. Very good. You guys got it. Shout out. A lot of you guys were very close. Not that you had a ton of options there, but I'm happy it was above 0, certainly. So my point here is that when someone holds their breath, they're going to feel miserable there. Eventually, your body will lose consciousness and it will force you to inhale again. But maybe not before those seizures kick in. When your brain goes hypoxic, what happens? All of those neural connections that are normally firing to keep you alive go haywire and you convulse. It's not uncommon for individuals as they become hypoxic, whether in the operating room if there's an emergency or a crisis, or out in the field if somebody somehow gets asphyxiated in an accident or something, or if it's an industrial accident where nitrogen is causing their hypoxia, or in a capital punishment like this, to see the individual convulsing. Now, when you hold your breath, you're going to make this process longer because you saw, I held my breath, I maximized a little bit of oxygen in my FRC. Had I just inhaled 100% nitrogen, my FRC would be gone like that. I would be done like that. Maybe that would be more painless, but you can't hold your breath and expect to have that painful loss of consciousness. It's not the same degree of control that you have over your unconsciousness, like you have an IV that's not dependent on your pulmonary mechanics, your FRC, etc. Now, that's just the tip of how pulmonary physiology works here, but the point is that you need to decide for yourself how you want to land in this issue so you can vote appropriately and advocate for yourselves, and more importantly, to remember that our mental health matters so much. Cases like the murder that Kenneth committed, horrendous. What led to this happening in the first place? It likely did not come out of a silo, didn't come out of isolation. Remember that your mental health is so important. And let's do what we can to help protect ourselves and our loved ones and those around us from falling down this path where we even need to have this discussion in the first place. But do be informed when you're voting for these very controversial issues in your state, or no matter where you are in the world, if this is even on the ballot for you to vote on, and specifically what types of capital punishment, so you can be informed. Let's answer some of your questions here, because there were so many comments I saw coming in. And as always, if you learned something new, please hit that like button and share what you've learned with others. Bends are no joke, says Wendy Marino. Yes, the bends can be lethal when you're scuba diving. Caitlin says, what is nitrogen gas used for in medicine, Dr. K? Nitrogen gas itself, we don't really use. We use nitrous oxide, like I showed in the ventilator here, that of course has nitrogen in it. It's this blue little dial here. Nitrogen itself is used mostly in industrial applications, but for MRI cooling, nitrogen is used. So not really going into the body. It was experimented for in laparoscopic surgeries, but we use CO2 instead these days. I have not been hacking loogies, fortunately. I've not been sick recently. This is a question. How can they make capital punishment ethical if doctors cannot do it? Well, that is what we're talking about here today. It's a tough one. I don't know how to answer that. Theophany, yes, laughing gas is that blue one I just showed you there. It's actually very similar to ketamine. It's the OG psychedelic, if you will. Although, of course, other psychedelics were in use far before this, but in modern medicine, if you will, as NMDA receptor antagonism, similar to ketamine. Why would COPD patients take nitrogen slower? Well, that's a good question. Depends on how much lung capacity they still have available to them. You typically have a bigger FRC in COPD, but you also, depending on the severity, will have less DLCO2 or the the uptake of oxygen, depending on how much fibrosis there is in your lungs. So it depends on the balance between your FRC, which is expanded and you have more oxygen reserve, versus how much oxygen you can actually absorb. And if you're already hypoxic at baseline because of your COPD. Does propofol taste good? No, it actually tastes horrible. This stuff is squirted in my mouth before, and it's really, really disgusting. Canada's euthanasia. Canada is one of the few countries in the world that has this euthanasia, this doctor-assisted suicide. And there's a lot of controversy there as well, because usually anesthesiologists are not the one doing it. Usually it's family medicine doctors. And there's lots of concern around how do you render someone unconscious if you're not actually familiar with the medications that do render unconsciousness, like urine surgery. Is the bends when you get air bubbles in your venous system? It's when you get air bubbles really anywhere in your body, but they're most problematic if they end up in your brain, causing you to black out. And it can be very, very dangerous, absolutely. Lots of great questions. Oral meds certainly can be used. They typically use lots of oral opioids. No question about that. But if you want to render someone unconscious quickly, oral medications are going to be, of course, slower than IV medications. Dan S. asks, when was anesthesia invented? Depends on what you define as anesthesia. The first public demonstration of inhaled ether, this is ether, but you get the idea with the mask, was in 1863 in Boston, Massachusetts, close to where I did my residency. And it has since then evolved. But originally, the poppy seed, cannabis, and alcohol fermentation processes were used to generate substances to very unsafely render individuals unconscious to have surgical procedures. There are very good examples of bends all over the internet. Very dangerous. You got to follow your dive tables to protect yourself. Why not use these medications? It's a very serious question. Happy Peony doesn't really match your username. In terms of those protocols, some of these medications are used, but opioids do not render unconsciousness typically, unless the doses are sufficiently high. But like I was saying, hydromorphone, aka Dilaudid, has been used in some of these. So it is an option. There's just a lot of controversy in even developing new medications and who is administering them if it's not a doctor. That's why it can be so challenging. Heidi, thank you so much for the super thanks. And Keith Brunson, the Hippocratic Oath. Yes, do no harm. MDs would not do this job. No, we have oaths. This is why there is a risk of losing your professional standing and your certification if one does this. That's exactly what many of these controversies surround for MD involvement. Well, the topic here, Jojo, was awfully deep. You may have to watch some of the rerun. It was about the ethics of doctors being involved in capital punishment. Does this rag smell like chloroform? How do I answer that? Why do they have anesthesiologists in the room when I get put to sleep? Because I have partial seizures. Well, whenever you're being put to sleep, there should be an anesthesiologist present, regardless of your epilepsy status. Getting fent and going unconscious, well, you may have gotten something other than fent. You can certainly go unconscious, but it typically takes quite a high dose, at least to render general anesthesia. And if we want to really make sure that somebody is unconscious, we typically have to use other medications in addition to the fent. So it's a tough topic, lots of bad drugs at play here, as you can imagine. Now, smokers' lungs versus non-smokers' lungs. Now, COPD is one of the big differences, that functional residual capacity that I mentioned earlier is much higher in smokers who have COPD, but they also have more fibrosis, which can compromise their uptake of oxygen. Oh, this is a very fascinating question. Does ketamine help with alcohol withdrawal? Well, you have to talk to your doctor about this. There are certainly studies, a big one in Nature, looking at ketamine for alcoholics and curbing their addictions. But for withdrawal, it is not typically one of the medications used. Propofol or GABA-A agonists like benzodiazepines are the mainstay. Have I met many patients not reactive to nitrous oxide? No, I have never met one. And MW, you are absolutely correct. It is a very, very tough topic. Can propofol like benzo slow your heart rate to the point it stops? Yes, it can. It can also turn off the signals in your brain. It's why we use it for isoelectric activity for certain brain surgeries, especially for aneurysm clipping. Can I explain the process of spinal chemo? No, I need a little bit more context to talk about. Really interesting, always. I am usually awake in 10 or 15 minutes of propofol, if that is all they give me. Depends on the dose and how much they gave you. Enough propofol will render unconsciousness very quickly. You can hum depending on how sedated you are. When you have the breathing tube in place, you can vocalize around it, and it can sound like humming sometimes. Helium is a very interesting point because helium also can if you keep breathing, it will eventually cause you to become hypoxic. So when we talk about the nitrogen hypoxia method, it's kind of like you're breathing a gas that doesn't make your voice very high like helium, but it's another example of what it's like to breathe a gas that's not oxygen. It takes you some time before you realize that, oh my gosh, you're becoming hypoxic. Why not ketamine? Then sucks IM. That, there's many protocols. That is one of them that has not been typically proposed. There's not very many doctors who want to devise these protocols. In fact, the one that I mentioned with the sodium thiopental and pancuronium potassium fluoride was developed by an anesthesiologist, from my understanding. Very controversial. But you could do ketamine IM, succinylcholine IM, and then cause somebody to die that way. But how are you ensuring the unconsciousness of ketamine if you don't have a doctor there? How are you obtaining these drugs? Is it painful? There's a lot of questions there that have to be answered. But it's certainly one of many ways of, I guess, skinning the cat. Horrible analogy for a horrible problem. They used different drug during the Korean War, and the mass units to render patients unconscious for surgery. I'm not familiar with that. It's a good question. I am afraid of pain of the breathing tube removal. Yeah, that's certainly painful when we remove the breathing tube, and that's why we want to make sure we're giving medications that help numb the airway, whether it's steroids to help with post-intubation sore throat, IV lidocaine, or topical lidocaine, or topical ketamine, or topical steroids, all sorts of treatments to help minimize that sore throat. Chewing gum before has been shown by the American Society of Anesthesiologists publication to also minimize that pain, that sore throat after intubation. And Katie, good to see you on here. Shout out to you. And Susan Roberts, good to see you on as well. What is the least common drug the anesthesiologist can give a patient? Well, in the United States, we barely use barbiturates. I've used methotrexate once in my career because propofol is just so effective and so common. I'm very, very happy that we don't have these shortages of propofol, as do other anesthesiologists. My most favorite non-medical thing to geek out about would have to be, please don't make fun of me, but I like Star Wars. I'm a big Star Wars fan. Maybe the OG Star Wars, not the new ones, but very good question. Gosh, I geek out about medicine a lot. Heather, very good to see you on here. Nitrogen gas versus carbon monoxide for hypoxia. Well, both of them can cause it. Carbon monoxide poisoning actually can very quickly displace oxygen on your hemoglobin, making it even harder to recover. So even if you get the 100% oxygen after carbon monoxide poisoning, it takes time for the hemoglobin to offload the carbon monoxide and replace it with oxygen. So it's very, very lethal, which is why carbon monoxide monitors are required under so many codes to help prevent these catastrophic accidents that can happen. GST fanatic, good to see you on here. Good to see you on here. If you weren't an anesthesiologist, what doctor would you be? I don't know if I would be a doctor, but as you know, I'm also an integrative medicine specialist. It's not the same as being a shaman per se, but it is using plant-based medicines, wisdom from cultures from around the world, integrating them with our Western medicine to give patients the care that they deserve by holistically addressing them, not just treating them like a pill mill or like we're in a meat packing factory. I believe the gas mixture was thiopental and nitrous oxide. Well, thiopental is an intravenous medication. Nitrous oxide is a gas, so it might be tough to have them both in gas form. Yeah, dry ice, also something else you don't want to be inhaling 100% of. Well, let's end with a fascinating question. I'm on nitroglycerin spray for my angina. Can you take too much? Well, yes, you can certainly overdose on anything. Nitroglycerin can cause horrible headaches as it vasodilates the blood vessels in your brain. It can help relieve heart pain by vasodilating the vessels in your venous system in your heart and help promote greater blood flow. But nitroglycerin, you got to be taking with your doctor's orders, and you want to ask your doctor, of course, these questions. But nitroglycerin may be applied topically to also promote vasodilation in areas that need greater blood flow, including some places after surgery, like your toes. You have to be careful how you use it, of course, but nitroglycerin is a fascinating medication, not only for the heart, but for the rest of your body and how it was originally discovered in dynamite mines. So, yeah, like Susan said, bad headaches, you're absolutely correct. Well, okay, I'll end with this one. Will the anesthesiologist let you do a spinal instead of general anesthesia for lower laparoscopy? Typically, no, because if you have a spinal, you are kind of awake. And if they're pumping up your abdomen with gas for that laparoscopy, if you don't have a breathing tube, it might be difficult to breathe against the inhaled, or the laparoscopic, what we call insufflation, that pressure in your abdomen. You have to be able to breathe against that. So when you have a ventilator here, the ventilator is pushing gas and oxygen into your lungs to push against the pressure in your abdomen. If you're breathing on your own with a spinal, it might be very difficult to generate enough pressure to breathe against that insufflation pressure. Anyways, I hope you all learned something new. If you did, please share what you learned with others. Consider joining the exclusive access. The link is below. Subscribe to keep up with all my lives. Let me know below what else you want to talk about. We want to talk about controversial issues if it helps better inform you to advocate for your health and for your loved ones. Till next time, remember that you have more power over your health than you've probably ever been.